Dr. Rajesh, a familiar face to all of us. He is an anesthesiologist and coordinator at Baby Memorial Hospital, Calicut. He is my neighbor. He's got COPS Award, Member Editorial Board, Indian Journal of Anesthesiology, Associate Editor, IJA South Edition, Kerala SA Journal, BMH Medical Journal, Past President, ISA Calicut City Branch, Academic Chair, ISA Kerala State Branches. He has several publications and has been a faculty in several conferences. So, over to Dr. Rajesh.
Thank you, madam, for the nice introduction. And at the outset, I should thank the organizers for the wonderful arrangements and for the kind invitation. And there is no conflict of interest, except that I have used some Google images. So I don't think that won't be a problem. And there is no financial support. I'll start with an opening remark from Galen, who was probably the first scientific writer in medicine. It is evidently impossible to transmit the impression of pain by teaching, since it is only known to those who have experienced it. Moreover, we are ignorant of each type of pain before we have felt it. So that means it stands still now, even though a lot of advances has happened in the pain medicine, and as Dr. Muralidhar said in the intervention part also. So coming to the topic, it's a neuropathic pain was initially described as caused by a primary lesion or dysfunction in the nervous system. And later on, that International Association of Study of Pain, that is the only organization which has study in it, and it's constituted a task force in 2018 and adopted the recommendation in 2011 as pain caused by lesion or disease of the somatosensory nervous system. So the word dysfunction they have dropped. And the thing about chronic pain, neuropathic pain, is that it persists in the absence of tissue injury and inflammation and doesn't have any protective role as in acute pain. And it has got a prevalence world over around 3 to 17%, and the prevalence could be much higher in selected group of patients like diabetic or onco patients. Now we'll go through the lectures. We'll describe briefly about causes, symptoms, mechanisms of pain, assessment, treatment options, and finally summarize. I will try to stimulate some interest on the topic in the given time. So the causes could be either due to nerve injuries, medical conditions, or post-chemotherapy, like patients after trauma or accidents, or post-operative neuropathic pain, which is very common, and nerve compression pain or entrapment neuropathy, which you get in post-hernia patients, open hernia patients, and diabetes, multiple sclerosis, viral infections, and post-chemotherapy. IASP, International Association of Study of Pain, in 2017 came with a coding for international coding for diseases 11 as neuropathic pain under 9 categories. One is peripheral and neuropathic pain, and peripheral again divided into trigeminal neuralgia, nerve lesions, painful neuropathy, post-herpetic neuralgia, painful radiculopathy, spinal cord injury, head trauma, stroke, or multiple sclerosis. So what are the symptoms patient can have? Patients usually come and say that I have got pin and needle sensation all over the body, or sometimes stabbing sensation, shock-like sensation, which come off and on, and throbbing sensation, burning sensation, shooting pains. And it could be continuous or paroxysmal. And once patient develop a chronic pain, there could be associated motor or autonomic disturbances, which is very common. And the thing is that it significantly impacts the quality of life of the human being. That's important for us. So two terminologies which is often expressed in association with chronic neuropathic pain is allodynia and hyperalgesia. Allodynia is simply a pain experienced from a stimulus that would go normally unnoticed. You can see there the threshold for pain in a normal before the threshold of pain for the normal patient develops pain. That is allodynia. Whereas in hyperalgesia, it is an exaggerated painful response for a stimulus which is usually very mild. You can see it the graph is well depicted. I think it is very clear. But you should know that chronic pain is not in isolation. You have to think of biopsychosocial model of pain to treat it properly. And it's always a personal experience that is influenced by varying degree of biological, psychological, and social factors. And it is very difficult to measure with a biochemical test about the extent of pain and one person is suffering. So when a person reports of an experience as a pain, it should be respected. And I mentioned about biopsychosocial model. It is that painful patient has got a painful injury or inflammation of the joint, which causes emotional reactions because it's not going till the last 3-4 months. It is continuously going on, which is affecting his financial involvement. His daughter's marriage is coming, which he could not participate to in full extent. It's interfering with the quality of sleep. So you have to take account of all these factors when you are treating pain. So let us come to the mechanism of pain. It is in nociceptive pain. There is it's very simple. You have a peripheral nervous system which conducts the pain to dorsal horn and then to higher centers and thalamus and somatosensory cortex. There you have experience pain and also influenced by the descending somatosensory cortex. But in neuropathic pain, which extends a minimum of 3 months beyond the acute onset, there is a lot of structural changes happening in the nervous system. Like in the central nervous system, there is hyperexcitability, inhibition of controls, loss of inhibitory controls. You have a descending tract which is inhibiting the pain sensation, which is lost, and reorganization. And in the peripheral mechanism, membrane hyperexcitability, ectopic discharge, which is responsible for the off and on patient complaints of breakthrough pain, transcriptional changes, and all these leads to sensitization of the peripheral and central nervous system. So this is the mechanism at the molecular level. Sensitization of the nociceptive receptors reduce the threshold for activation and enhance the response to stimuli at the peripheral changes, and at the dorsal hood ganglion it's an enlargement of the receptive fields. And then once the receptive fields enlarge, patient will develop allodynia or hyperalgesia, independent firing of the A delta and C fibers, and increased expression of sodium and calcium channels. And the central changes results in what is known as wind-up phenomenon, which is sensitization of the spinal cord neurons with the loss of central inhibitory mechanism and enhanced nociceptive transmission and upregulation activation of the central NMDA receptors and role of genetic factors. And at the molecular level, all these things happen, which results in the brain remodeling and peripheral sensitization and central sensitization. But ultimately, to the patient, it turns, when the acute pain turns to chronic pain, and it results in anxiety. Why my pain is not relieving? And the brain becomes more focused on the problem, and finally the patient develops the biopsychosocial model of pain which I described. So how to approach to the patient? You have to evaluate the patient. You have to explain what is wrong with the patient in simple terms. There is no point in telling the patient that you have got the complex regional pain syndrome 1 and I am going to give you stellate block, physiotherapy, etc. You have to put it in simple words, and you have to finally manage the pain and review the patient continuously, and you have to give attention in detail to whatever the patient says. And ultimately it is a teamwork. You have to chip in sometimes for the diagnosis work and medical management, intervention, behavioral, psychosocial support, community support, and finally rehabilitation. So how to evaluate? You have to see what is the cause or mechanism of pain. That is the first thing you have to look into. And the non-physical factors responsible for or aggravating the pain or attributing to the pain, drug history, or if is already on step 2 medications or step 1 medications, how to step up the medications, what is the scope of interventions, everything will come in that, and impact of pain in patient's life. And evaluation must always precede treatment. Before prescribing drug or before going into intervention, you have to evaluate the patient. It's very important to have a good rapport with the patients, because you have to continuously see all these patients. And once the patient is before you, you have to encourage the patient to do most of the talking. So this is the pain chart which we do in our institution. You can do different types. You can see the body chart. You can see the point is not working. You can mark the site of pain, duration, intensity, whether it is a superficial pain, deep pain, nature of pain, whether it is a relation to movement or any aggravating or relieving factors. Everything you can put it here. You can mark the chain. Suppose the patient has lower limb neuropathy, you can say front or back neuropathic pain, VAS 8/10 in the first visit, or then the subsequent visit when it has with their medication, it has come to 4 or 3. Like that you can see, and you can see you can plot the family tree, whether there is a similar history, uncontrolled diabetes in the family, and patient's insight into the diagnosis, whether especially important in the malignancy cases, and social and emotional factors affecting the quality of life. And different pain scales are there. I am sure you must be very familiar with this visual analog scale or numerical rating scale. And diagnosis usually by history and clinical approach, examination, and classically there is a 3L approach described in textbooks like listen, locate, and look. It's nothing but listen to the patient's verbal description of pain, and locate the pain region and document in the chart. Look for simple examination of the somatosensory function and sensitivity to touch, cold, heat, and pain. And imaging techniques are there which accurately locates the location of pain, like metabolic functions of the nervous system, functional or anatomical studies, imaging studies, all these things you can adapt to. And for neuropathic pain, there is specific screening tools like Dollar Neuropathic N4 questionnaire, leads assessment neuropathic symptoms and signs, pain detect scales, and neuropathic pain questionnaire. I will put one here. This is a pain detect questionnaire. You can chart it. It will be useful for research paper and further assessment of the patient. And now you have assessed the patient and you know what is the wrong with the patient. You put across the patient in simple words and discuss the treatment options. It's always important before treating to correct any correctable causes. There is no point in treating pain without correcting a correctable cause. And management, pharmacological and non-pharmacological, we use antidepressants, anticonvulsants, topical agents, opioids, non-pharmacological physical therapy, rehabilitation, and transcutaneous electrical nerve stimulation, nerve blocks, interventional spinal cord stimulation, Dr. Muralidhar said, and surgical decompression, brain neuromodulation techniques. So there is evidence-based like guidelines for first line, second line, and third line, like so many associations have come with their guidelines, but it is more or less the same. International Association of Study has come with the guideline, and so also UK guidelines are there. There is a first line, but if you go through that, the drugs are almost the same. First line, second line, third line, and opioids as a last resort, especially in non-malignant pain conditions. And the dosage also is there, the starting dose and subsequent doses. And now the trend is to use combination therapy, medical management for neuropathic pain, combination of drugs at lower doses over maximum dose of each drug. So the principle is that drugs with different mechanism of actions will complement each other for this analgesic effect. And it is now the trend is to go for sequential combination therapy. You try with a lower dose of one drug. If it is not working, you start with gabapentin. If it is not working, you add amitriptyline or vice versa, or you add tramadol. The future combination is gabapentin plus opioid plus tramadol. Tramadol is opioid, weak opioid. And the classic study is the Combodian study, which was on diabetic patients with the diabetic peripheral neuropathy. Here, they have two sets of patients. One with the combination of pregabalin and duloxetine at lower doses, and second group was each agent at the higher doses. And it has conclusively shown the superiority of low dose combination therapy with the better patient compliance and less of side effects. So there are interesting other drugs coming also. There's capsaicin patches, intravenous lidocaine is now used, topical clonidine has come, and topical creams of ketamine 10%, gabapentin 10%, imipramine 3%, bupivacaine 5%. So can you someone recognize this gentleman is actually David Julius. He and his team in 1997 actually cloned the capsaicin receptors for which he was given the Nobel Prize. Such is the importance in any intervention in pain. There is a large area or large scope for further research and intervention, but it's not easy. So he was awarded Nobel Prize in 2021. Now, other trend is drug repurposing. It is not easy to invent a molecule, get the ethics clearance, try it in animal models, then try it in humans, and then extrapolate in the disease conditions. You have to do lot of drug trials. Now, but drug repurposing is a much better option. An NMDA receptor antagonist, or ketamine dextromethorphan, is now used for neuropathic pain. So also amantadine, which is used for Parkinson's use in disease, botulinum toxin, and mexiletine, which is an antiarrhythmic agent. And I'm not going to interventions. Joshi sir has already described. So neurostimulation, transcutaneous electrical nerve stimulation is there, which is conventional. And I think it is because it's not a very harmful technique, you can go for it, but results are not much great with TENS in neuropathic pain. Subcutaneous spinal cord stimulation, all these things effectively, the principle is gate control theory by Melsack and Wall. This is the inhibition of pain transmission through effects on large afferent pathways. Now you can use epidural motor cortex stimulation, and this two techniques which has come recently, Joshi sir has mentioned it. Repetitive transcranial magnetic stimulation and transcranial direct current stimulation. I have seen the images, but I don't know whether anyone is using in India. It's using in India. Okay, good. But it is non-intervention techniques. And interventional treatments, erector spinae block, I used to give it for thoracic postherpetic neuralgia. Dorsal and it blocks the dorsal and ventral rami thoracic nerves, and deep brain stimulation, which is used for refractory chronic pains. And now anterior cingulate cortex deep brain stimulation, which is for failed pharmacotherapy or for 2 years or failed deep brain stimulation. Is it there in India? Anterior cingulate cortex deep brain stimulation specific to. So there is dorsal root entry zone ablation for neuropathic pain, which for complete spinal cord injury, which is, targets the nociceptive fibers in the lateral bundle of dorsal rootlet and deafferentated neurons in the dorsal rod and medial portion of the Lysair tract, which is mentioned in the diagram. So now there is individual approach. That is, there is a huge inter-individual variability in response to drug. So some patient will give a response to 10 for the same pain 10 milligram of morphine, but 10 milligram Q4 other patient may not respond. So now there is a scope for pharmacogenomics. It has come in many parts of the world. It has come for in onco medicine treatment. You see which patient will respond, which patient has got the predominant neuroinflammatory marker, and how will he respond. And it is taken to electrophysiological difference and imaging techniques. So now the thing is that it is going to be the future. Any of the patient postgraduate sitting in this call, so there will be a barcode on the patient, and patient will come to the OP and you will screen the barcode. Yeah, this patient will respond to the gabapentin, or this patient will respond to tramadol or morphine, like that. So to summarize, there is a huge suffering around with 3 to 40% as adequate drug therapy related pain relief. So there is a huge scope for advanced interventions which is coming, and similar to sensory, it is considered as similar to sensory hallucination that can occur after damage of the sensory system. And I have shown the two guidelines, evidence-based management guidelines, NICE and IASP. It's more or less the same. And the trend is now to sequential combination therapy, drug repurposing, and individualized therapeutic approach, pharmacogenomics, neurostimulation techniques. Thank you for the patient listening.